Okay, good afternoon, everyone. Thanks for coming to our first MUCHE seminar of 2023. My name is Professor Henry Cutler. I'm the Director of the Centre for the Health Economy at Macquarie University. Today we have a very special guest, Dr. David Cullen, who's an adjunct professor at Macquarie University Centre for the Health Economy. For those of you who are familiar with both the aged care and disability care sector, you probably know who David is. But for those who don't, David was the Chief Health Economist at the Department of Health, was involved in the Living Longer, Living Better reforms significantly, and also the Royal Commission as a special advisor, but also has recently been the Chief Economist of the National Disability Insurance Agency, but also recently retired. We are very excited to have you today, David. David has spent quite a while in the public sector, and that means he knows where the skeletons are hidden. So hopefully we'll get a little bit of that today, but his presentation will be on reflections of a former chief economist on 2 decades of failure in social care policy. So David will present, and then we'll open it up to a few questions. Please, if you have those questions, put them in the chat. Okay, without further ado, over to you, David.
Thank you. Thank you, everyone. It's been a long time since I've given an academic seminar, so hopefully you won't all be too bored. Let me just panic because this is not working.
Yes.
I'm sorry, everyone.
Best laid plans of mice and men, right?
Yes. Shall we try one of those? Okay. I just have to click it. Okay. Let me see if I know how to do this. Oh, it's not going to work for me.
Make sure it's where's the oh, there we go.
Okay. So, is it this one?
Yep.
Yes. Thank you. Now I know how to work it. Thank you. I told you it's been a long time since I've given a seminar. I begin by acknowledging the traditional owners of land on which we're meeting and their elders past and present, and declare my support for the Uluru Statement of the Heart and for a voice to Parliament. Voice to the nation. I also give a disclaimer that the views I give here are not those of the Australian Government or the Department of Health or the National Disability Insurance Agency or anybody else in the world other than myself. So basically today I want to talk a little bit about what I call Australia's social care system. Then I'm going to concentrate mainly on aged care. I'm not going to say very much about the NDIS today because I still am doing a little bit of work in the NDIS for the government. Then I'll talk about what's wrong with the current system and why I think it is, why that's happened, and what we can do about it for the future. Okay, so when I talk about the social care system, I'm essentially talking about the age pension, the DSP, disability support pension, aged care, disability support and carer payments, which account for about 6% of GDP. About 15% of the population get a payment through that system, 137 billion in today's dollars. And yeah, 4 million people are actually supported by the social care system. That's what I mean by the social care system. Basically, you can see that it's, well, you can see what it is. It is what it is. Pension, age pension, followed by aged care, followed by disability support, followed by the DSP. Okay, and these things are run very differently to each other, of course. The age pension is like 100% funded by the Commonwealth. That's a complex statement there because there are a lot of people in retirement incomes who are not funded at all by the Commonwealth, and there are lots of people on the age pension who part fund their age pension because of the means test. But insofar as the government money is concerned, it's all funded by the Commonwealth, obviously. The DSP is the same, funded by the Commonwealth. Aged care is about 80-20. There's a little bit of state government money there for some reason. Disability support is like 60-40 on the states versus the Commonwealth, nothing from the individual. And that 60-40 is going to change considerably over the next 10 years. Essentially, the state contribution is fixed, and the Commonwealth has taken the sort of upside risk on any growth in the NDIS itself. or at least that's what the states say. And carer payments, which are again 100% funded by the Commonwealth. And altogether, the social care system essentially spends 27% of all government revenue. So it's kind of a major thing that the government does. And as I'll point out later, it's a major thing that the government does very badly. Workforce, there's about 340,000 workers in aged care, 3,000 service providers. On the other hand, if you look at disability care, it's got about, at the moment, 300,000 workers. And last year, 180,000 businesses sent the agency a bill for something that they've done for a person with, so the NDIS is really founded around this sort of individual purchasing. The individual gets a package of money, they spend it. The result of that is that 180,000 different businesses offer supports to individuals. Now, a lot of those got $5. You know, the local chemist sold a packet of continence pads or something like that, you know, but a lot of them are quite big as well, okay? But it's just a different, it tells you that it's a totally different economic relationship between the funder and the business community. Workforce, massively growing, as you all know, 17% growth the next 5 years. And that 17% is before the government committed to an increase in the number of care minutes that will need to be delivered in aged care, which adds another 20,000 people who are needed. And before the growth that's now projected for the NDIS was factored in. So the actual growth in social care workforce must be much more than that over the next few years. It's already going to have to grow at twice the rate of the economy as a whole, and it's probably going to have to grow at faster than twice the rate of the economy as a whole if it's going to solve its problems. Just wanted to quickly show this couple of graphs, because I think people don't really understand how the social care system differs from a lot of other systems. This is essentially just a sort of like standard kind of multiplier graph, which basically looks at what the output is. One of the interesting things is that people often justify the NDIS, for example. There's this paper, famous paper, which goes around that the industry paid for, which basically says you should pay for the NDIS because it generates $2.5 for every dollar that you spend in it. Now, as we economists know, that's not very good. It's not too bad, but it's not very good. And that mostly, you know, because of the way an economy works, whenever you spend money, it goes around in a circle a number of times and you spend a lot of extra money on it. So you can see that aged care is not too bad in terms of its output multiplier. It's about, you know, 2.7 or so, which is kind of bigger than a lot of sectors and less than some sectors. What's really different about aged care, of course, is its employment multiplier. Because everybody in aged care is low paid, and because they buy their services that they buy from low paid workers, you get a lot of extra jobs. Every time you spend money in aged care or in disability services, you produce a lot of jobs in the economy. Or inversely, every time you want to spend money in the aged care sector, you've got to find a lot of people to deliver those services, because each dollar you spend has to be delivered by someone. So aged care kind of works differently and in a kind of like a different way to many other parts of the economy, and this just brings that out. And this is the other sort of, on the other hand, again, from an income point of view, and I suppose this is almost like from a taxation point of view, like the income multiplier for social care is higher than any other industry. And again, that's not surprising because, and it's one of the few industries which got an income multiplier greater than 1. And that's not surprising because they're all low paid, so they have no savings, and they all buy this, and they don't buy anything from overseas. So all the money goes around in the Australian economy, and yeah, so it's not surprising. We all know why the number is greater than 1, but it is a fact that these are differences between this sector of the economy. This plays out sometimes because when you're in a government which is saying, how do I boost the economy really quickly? You basically say, throw some money at aged care because you're going to create a lot of jobs and you're going to create a lot of income, and you can get more return on your dollars. If you're trying to boost the economy, you boost the economy by throwing money into it. If you want to boost the economy quickly, you throw money into aged care. If you want to boost the economy over the long run, you throw money into infrastructure. You know, but these are just some of the thinkings that go on in government when government does thinking. Okay, so this is a history of how the government has spent money on social care. Taken me a long time to put together because, believe it or not, governments try very hard to hide how much money they spend on everything. It's quite interesting if you read, I basically read every annual report published by every government department since 1900. And if you read annual reports up to about 1980, you actually know what happened that year. If you read government reports after 1980, it's kind of a little bit more difficult to work out what happened that year. But you can see that the age pension basically has always been the biggest social welfare payment of the Commonwealth and was pretty well out of control until the 1980s, when essentially retirement income policy, etc., and superannuation started to get it under control, and it's coming down. I'll show you some projections later. The disability support pension basically has been, that's the orange line, I think. Basically, it's grown significantly, but it's never really got out of control, and it's under control. The aged care spending, as you can see, is beginning to grow quite strongly. Commonwealth didn't get into aged care until about 1955, and I'll talk about later why they got into aged care, but it's grown quite strongly since then. And then you've got disability, which is the green line at the bottom there. Commonwealth hasn't really done anything in disability until mid-1990s. Until then, it basically said that that's the state's responsibility. Then it started to get involved through some transfer payments, and now, of course, it's begun to take on the NDIS. And I think you can see the curve at the end there and where it's going in terms of the Commonwealth expenditure on the NDIS. And I'll come back to some projections later, as I said. Okay, so now let me talk about aged care a little bit, which is that kind of bit in the middle, the 1.5 million people, 6% of the population, you get $31 billion. About 80% of that from the Commonwealth, about 20% of that for ourselves, 1.4% of GDP. So let's talk about that. I'm sure you all know a lot of this, but I'm going to talk about it. Important to understand aged care and how aged care policy has always happened in the Commonwealth. Aged care kind of lies at the nexus of the health system and the welfare system, and it's never really been sorted out in the Commonwealth where it should sit. It kind of, in terms of the administrative arrangement orders that the Commonwealth works under, it kind of, the aged care part of the department wanders around from the health department for a few years, and then it wanders over to the Department of Social Services for a few years, and then it wanders back again. But that makes a difference because those two systems work in a totally different way to each other. And the two people who lead those systems and the policy formulations for the health system are different than the policy formulations for the welfare system. So the fact that it kind of wanders around between them can confuse you. But essentially, there's been a consistent kind of direction in Australia, which is subsidised services, but subsidise them as little as possible, but also subsidise services rather than giving income support. There are many times in the system where government, over the last 100 years, where government's been faced with a problem in like the 1950s, 1960s, there was a housing problem for old people. And government had two choices. It could basically increase the age pension so that they could afford housing, or it could create a housing program which targeted money specifically to that for a few people who chose to do that. So the whole hostel program in aged care came about because there are a lot of people who didn't have secure housing, and government had to find a way to solve them. But if it put the age pension up, then it has to put the age pension up for everyone, including all of those who were long before old age. So instead, it invents this other program to the side called hostels, where it's now going to pay the accommodation costs of very old people who have a healthcare need, but that's cheaper than putting up the age pension for everyone so that they can solve their housing need. And that happens quite a few times. Essentially, aged care policy inherits from the welfare system this kind of concept of needs testing, and you should only get as much as you need, but you should look after yourself. And from the health system, gets things like quantity rationing, and which is kind of like a weird thing to do in a system which you're now trying to claim as a market, but you're still going to kind of measure quantity and co-payments. All right, so moving on from there. So this is Australia's healthcare system. I'll just give you a second to this is the aged care system, and take that in. But this is probably more. It's very confusing. Okay, no one understands the system. No one understands why all the parts of the system exist. And a lot of the reasons why parts of the system exist have been forgotten by people. They've lost over time. Or something really interesting tends to happen, which is that a system is created for one purpose, but it then creates an expectation and it moves to another purpose. A good example of that is home and community care. Home and community care was designed in 1985 with the following principle in mind: spend as little as possible, but as much as necessary to stop people from going into nursing homes. Because nursing homes cost a lot of money. Don't try and meet all their needs at home, but try and meet enough of their needs at home that they'll decide not to make the shift to a nursing home. But what it then became was a program which was giving people things. And of course, when you have a program which is giving people things, lots of people want those things. And then it starts to get more demand on it, and it kind of loses over time what its original design purpose was, which was not to meet everybody's needs, but to meet as few of people's needs as was possible in order to, as necessary in order to stop them progressing to the next system. And that's happened time and time again in the aged care system and possibly in another system, which I'm not going to talk about today. Aged care, again, this is kind of like just the growth in aged care. We know that the sort of GDP growth, that's the line. The kind of makeup there, you can kind of see that, you know, the orange there is residential care. That's where all the money has almost always been spent. But, you know, these other programs have gradually come through. I have a better chart than this in a moment. So let me move on from there. Yeah, so the aged care system, what do we have? Well, we have assessment. 100% of people get assessment nowadays. You don't get aged care without assessment. 1.3% of the program budget is spent on assessment, and it's a pretty good 1.3% of the money. It's pretty sensible to invest 1% of the money in making sure that the rest of your money is well spent. So that's what the assessment is for. Home support supports about 2/3 of all people in aged care, and they get about $3,800 each. It's still kind of performing to an extent that sort of low level. At the moment, that low level, let's just give people what they need or the minimum necessary. Home care is where you get into community care packages, etc. And that comes up to about 25,000 on average. And that's now 17% of population, you know, whereas when I began in aged care in the late 1990s, you know, there were a few hundred packages in the country. Residential care looks after 19% of the population, but spends 60% of the money because they're the really sick people. And then there's some odds and mods which come at the end. Flexible care is kind of like rural and remote and flexible transition care, specialised care, and Aboriginal and Torres Strait Islander care. Large amounts of money for a small amount of people, but that's necessary because they're specialised populations. Okay. So I guess the question is, we spend a lot of money and we're totally failing. Okay, the Aged Care Royal Commission was absolutely scathing. You know, we spend all this money and yet people wait months/years for the care that they need at home. When they get the care that they need, they don't get very much care. If you get the highest level of home care package, you get 1 hour of care a day at home from a professional carer. Half of aged care homes have not enough staffing to meet the need. And then there are all these other indicators, which basically just say that, you know, half the people, according to half the people in aged care, are malnourished. Read that with a malnourishment can occur in aged care for other reasons other than mistreatment, but it shouldn't be that high. And, you know, and yes, we expect people to be incontinent, but these people are not actually just incontinent. Their incontinence is not being properly treated, which is what that statistic is saying. So, I mean, what the Royal Commission basically asked the question is, how can you have spent all this money and ended up with this disaster? And just to make it clear, it wasn't because providers took a lot of profit. Okay. I mean, these set of graphs here basically talk about the profit levels of residential aged care providers. And essentially, they're plummeting. On average, residential aged care providers make a loss. They've never made much of a profit. They now make a loss. Their operating results are kind of quite low. These are the average. I mean, there is a spectrum. A spectrum mainly reflects around the efficiency of the provider. But, you know, this is not the chart of a sector which can continue on in existence. So we spend an awful lot of money. It's not that it went into the pockets of providers, and yet we got really shit outcomes. Excuse the French. So that's what puzzles me. That's why, I mean, I'll be quite honest. I spent 20 years designing the aged care system. I know why I designed it the way in which I did. And now it turns out we know what happens when you design the system in that way. So why is it so? And basically, like I said before, the history of aged care is a history of a number of decisions about how much are people willing to spend on aged care. Or more precisely, how much do governments think that taxpayers are willing to pay? So from the very beginning, we had the age pension. Age pension comes in Australia about 1908. And, you know, it was quite clear when the age pension was introduced, it was only to be given to people who needed it. And the test was quite straight. You had to be totally unable to care for yourself before you were willing to get it. And indeed, the original age pension had some quite interesting kind of features to it. Features where you, your family could be taken to court for not looking after you, and things like that. And government stepped in at the end. And the amount of the pension, which was basically £1 a week, was quite low. But that was the sole kind of support that there was for older people. Everything else happened. In the sort of one step before here, which I think I've missed, but in 1955, nursing homes were invented by the Commonwealth. Before that, nursing home patients lived in hospitals. Hospitals cost at that stage, on average, about 40 shillings a day per episode. And the Commonwealth decided to invent this thing called nursing homes and basically said, let's take these few hundred facilities and let's call them, don't call them hospitals anymore, let's call them nursing homes and let's give them 20 shillings a day because they're not really doing hospital care. So that's what happened. This whole set of hospitals, which were being paid for by the Commonwealth, split in two, and half of them were putting on a lower rate because it just didn't cost that much, the Commonwealth said, to care for old people. Then, as I mentioned earlier, later in the early 60s, there was this housing problem. There was a lot of debate about increasing the age pension, but instead what it was decided was to produce this capital funding. So lots of people were going into nursing homes, but nursing homes were actually built by people. The capital had to come from the nursing home. There were a large number, the capital had to come from the provider, and there just wasn't enough capital around. So government decided that it needed to start pumping money into the capital side of nursing homes in order to make sure that these things existed so that it could put people in there rather than have them in their hospitals. Recurrent subsidies for nursing homes, they've gone up, and like they began in 1965 is when we started having like actual kind of differentiated subsidies for nursing homes. And basically that's what I was saying, you know, you didn't want them going to hospital instead. In the 85 onwards, there was this idea that there must be alternatives. Nursing home care has become very expensive. Let's find all these other alternatives. And as I said, those alternatives were always designed to spend as little as possible to achieve the outcome. And the only outcome I wanted was that people didn't proceed to residential care. And then from about 2005 onwards, government started to understand that you couldn't achieve that aim if you didn't support informal carers. And so you needed to start informal carers. Now, let me give you, no, I won't give you, I'll talk about that later in the economic section. Okay, this sort of like talks about how the strategies have changed over time. From 1954 to 1964, and then later, the light green is capital funding. The first thing the government did in nursing homes was it just funded the capital. They said, you have to look after yourself, but you don't have anywhere. It's going to be easier for you to look after yourself if there's a building in which you can do it. So we'll build a lot of buildings. Then it started paying for subsidies. And then it started to invent these other kind of home support and home care packages, each of which were designed to keep people out of moving into this rapidly growing kind of bucket of money. Okay. Despite this, and I know this chart, government likes to concentrate on this chart and basically say aged care is out of control. That's the kind of share of GDP. But the reality is that government has consistently underfunded aged care since the beginning. What the blue line here does, it basically looks at like the transfer ratio. It basically says what share of GDP per person is spent on people who need aged care. So for each person who's 85 or over, well, this line says for each person who's 70 or over, what percentage of GDP is spent on their, take aged care. Aged care spend divided by the number of people aged 70 as a fraction of GDP per person. So it's kind of like a transfer ratio. So in some sense, my thesis about this ratio is that as a country becomes more wealthy, it can afford to buy high value goods. As a country becomes more wealthy, it can afford to buy things like, it no longer needs to worry about shelter and food. You can start to worry about healthcare and things like that. So you would expect that the percentage of money, the percentage of GDP per person that you spend on aged care should increase over time as the countries become more and more wealthy. It hasn't. In fact, if you take the 85 plus population as kind of like the demand population for aged care, then essentially from about 1985 onwards, government has essentially been making an efficiency saving in aged care. And that efficiency saving is driven by two factors. One is that the number of aged care places is driven until very recently by the 70 plus population, but demand is driven by the 85 plus population. And there's an annual efficiency dividend, which is imposed on the sector by this thing since 1996 called the COPO indexation, or the COPO indexation. Essentially the way in which aged care subsidies are indexed each year doesn't keep up with provider costs I move on from here. Yeah. So, chart on the far right looks at the comparative growth rates of the 70 plus population, which is the blue line, and the 85 plus population, which is the red line. And basically, as you can see, in every single year since the beginning, demand has grown faster than supply. So it's not surprising that, we've had less and less, more and more unmet need for care. And this chart over here basically looks at the blue line is the rate at which subsidies grew each year, and the red line is the rate at which aged care costs grew each year. And unit costs. So this is like the input costs for providers. This is sort of like wages and CPI, etc. So in almost every year since 1996, input costs have grown at a much faster rate than what subsidies were grown at. That's what I call the efficiency dividend. So the imposition of this efficiency dividend basically meant that there was less and less money to care for people, those people who did manage to get into care, and the planning ratio meant that more and more people were not cared for. And that explains exactly why we ended up in the position where the government said we were, where the Royal Commission found us, which was that people were waiting for care and the care that they were giving was no good. As the Commission also said, this didn't happen by accident. This was a deliberate choice of government. Now, I joined the public service in late 1997, I believe. This cabinet minute was written in early 1997. I want to make that clear. So this was written just before I joined the public service. But the 1997 aged care reforms were decided on by cabinet on the basis of advice from the department, which said, don't worry, because if things get out of control, we can control the number of people. Not only can we control the number of people, we can control the number of people who get high level care versus low level care. We can put this efficiency dividend in place, and we can control, well, this one says we control the overall number of people, and this one says we can control the number of high care versus low care people. So essentially, government knew when it went into the 97 reforms that it didn't have to worry about the cost of these because government had complete control over all the necessary parameters in order to stop the cost going out, which would have a care concern, but that matter wasn't dealt with in the paper. And as a result of that, if you put all of that together, if you run a model, essentially government should be spending twice as much. The planning ratio itself has saved 35 billion a year, and the efficiency dividend saved another, both those numbers can't be true. The 50% and the 35% are right, so this one must be lower. Yes. Okay. And essentially the bad quality care which has occurred as a result of that. So that's why we have an aged care system which doesn't meet the needs of people today. So now the question is, what's to be done? And now I'll give you some projections. These are projections out to 2060 of what we're going to spend on each of these programs. The top line again is the age pension. And as you can see, the age pension, government really does have good control over the age pension now, even though there are more and more people becoming old. Now, when I say government's got good control over the age pension, I'm not here talking about the tax subsidies which go into superannuation, which are the biggest tax subsidy that we have. So this chart doesn't talk about another thing which is out of control, which is that tax subsidy, which the Treasurer is talking about at the moment. But in terms of the age pension itself, the superannuation arrangements, etc., have got good control over that because the aging population is getting bigger and bigger and bigger, and yet the share of the government revenue, which is, well, share of GDP spent on the age pension will actually decrease over the next 40 years. At the same time, the share of government revenue spent on aged care will actually increase. And indeed, that's the red line. And indeed, what is it, the red line? It's the, whatever that line is. By 1960, government will be spending more on aged care than what it spent on the pension for the first time ever. So aged care is the big, well, until very recently, we would have said that aged care is the big problem that government has to face. And it's probably the biggest problem the government has to face as a result of the aging of the population. You'll notice I'm cleverly not talking about one line at the moment. The DSP, which is this line here, is similarly under well control. And the carer line is going upwards a little bit, but carers, after all, are an investment. And so one actually wants to see this line go up a little bit because the more money you spend here, the less money you have to spend in aged care. So there's a kind of trade-off between informal carers are a strategy in order to reduce costs. And of course, then there's the green line. And the green line is what the government will spend on the NDIS. And I have given the 10-year, there's a public 10-year projection for that number, and that's this number here, that's this dotted line. There is no, well, I'm not willing to draw a 40-year projection for that line, but I think you can see that even on the current public projections, in 10 years' time, the disability sector will cost more than aged care and almost as much as the age pension. And that's clearly an issue which someone might want to think about at some stage. And I'll say no more about the NDIS at the moment. So that's where we're at. And why has it happened? And there's a number of things why it's happened, but I'm trying to give you an example of the stupidity with what occurs in government, which I think sometimes happens because of a lack of institutional memory, but it also happens because a lack of institutional memory of why things were done in the first place. Take what's now called the carer allowance. It used to be called the domiciliary nursing care benefit. Now, care allowance is worth about $3,300 a year. And it's an allowance which is paid to someone who stays at home to look after someone else. Originally, it was introduced as a domiciliary nursing home care benefit as a payment to someone who would stay home to stop someone from going into a nursing home. Now, it's a payment which is made on top of a pension, so it's not an income support payment, it's a payment on top of the pension. When it was first introduced, the amount of the care allowance, I'll call it the care allowance, the DNCB, was equal to 25% of the pension. Actually, that's not quite true. It was equal to, the way in which it worked was this, and as you may know, when you're a partner living at home, you don't get 2 full pensions, you get 2 3/4 pensions. 2 people living at home get 1.5 the pension, they don't get the 3/4. The pension, the care supplement was equal to that other half. So what the government basically said was, if you live together as a married couple and you don't have any care needs, we'll give you 1.5 times the pension. If you live together as a married couple and one of you is caring for the other, we'll give you twice the pension. Because we'd rather spend that extra money on the pension than what it would cost us to spend on nursing home. Looked at it in a different way, the amount of that amount was equal to 57% of the nursing home benefit in that year. So when the DNCB was first introduced, essentially government said, 2 of you are living together, I've got 2 options. I don't pay you to care for your partner and your partner will have to go into a nursing home. I'll have to pay you both the full pension because you live far from each other, and I'll have to pay for the nursing home. Or I can pay you 1/3 of the pension so that together you get paid just what you were paid in terms of the of pensions if you lived apart, and I don't have to pay for the nursing home. It was quite obvious why you would do it, right? So the government was saving a vast amount of money in nursing home costs, and it was not paying no more than what it paid in pensions if people lived apart. Today, the care allowance is worth 5% of the pension. So we basically say to people, if you 2 live together, we'll give you 1.5 times the pension. If one of you needs to care for the other, we'll give you 5% extra. Or if you separate, we're going to have to pay you 25% extra because you're separated. It's not in government's interest for the care allowance to be 5%. Today, the care allowance is worth 7% of the nursing home benefit. So the amount of savings government could make from increasing the care allowance from where it currently is to something like, again, back to 25% of the pension would be enormous because it would generate more informal care at home. Now, why did this happen? It happened because the care allowance payment eventually went to the Department of Social Security, who thought it was a welfare payment and didn't realise that its only reason for existence was to encourage people to care for people at home to save money in the nursing home system. And so a saving was taken by indexing it at CPI rather than indexing it at the rate of the nursing home subsidy. Because it wasn't thought about economically is another thing. It was thought about, it's just a payment, we've created a payment, now let's worry about who gets it. Let's forget about why we're giving this payment and what the economic benefit of it is. So that's a good example of institutional memory failing. Basically, why do I say governance? What the Royal Commission recommended, and I absolutely support this fully, is that governments make choices every year in the budget, and they make choices with a vast number of different choices that they have to make because there are many different people Payments like aged care, problems like aged care don't sit well within that framework because decisions about aged care are then made in the context of other decisions. That's why the chair of the Royal Commission said there's only one way to fix this problem, and that's basically to create an aged care fund, which is self-financing through its own levy, and which is basically managed by an organisation totally separate to government. Well, maybe appointed by government, but it's a bit like the Reserve Bank. It's totally separate from government. A bit like the Future Fund is essentially an entity like this. The Future Fund can't be directed by government, but basically, it has all this money. And so basically that's what the chair of the Royal Commission said, is that the only way we're really going to fix this in the end is to create this whole separate fund, social insurance scheme, essentially. Now, I think I was asked yesterday, has anybody ever done this? And I was thinking, no one's ever consciously done this, but just recently I've been listening to the debates in the US where essentially, the US is having its annual, we're not going to pass the debt ceiling bill, we're going to kind of like argue about the budget. But both sides of government have now agreed that Social Security is not within that debate, that Social Security just has to be funded at the rate that Social Security should be funded, and they'll argue about the rest of the budget. So essentially they've done this. So there's reason to believe this can be done. We did this work in the Royal Commission, Bridget Ballard and I. Yeah, I'll talk about that in a minute. I'll give you an idea about how you fund this. But that's the first solution, I think, to the problem, which is basically to get aged care out of the hands of politicians. Not because politicians do badly and not because the whole budget process is a bad thing, but it's not a thing which is well suited to a problem like this. The other problem which we have to address is how to get rid of this kind of financing mismatch. Now, this stuff is all well known, right? But essentially, the number of people who are available to pay taxes nowadays is a lot lower than what it used to be, and going lower still. The number of people who are available to be workers in care is going down. Aged care dependency ratio is kind of getting like very low. It used to have I remember what side this is on that side. Back in the 70s, there were 120 taxpayers for every person in aged care. Now there are less than 20 taxpayers for every person in aged care. So it's getting more and more difficult to fund it because essentially the generation is growing at a different rate to the 15 to 65 plus population, and so the tax base is not growing at the same rate as the expenditure base. So how do you align those things? And that's essentially what social insurance is meant to do, right? Social insurance tries to align those things. We have this other problem, of course, because not only are the two generations growing separately, but income works like this. So this is where all the income gets raised in these years, whereas all the expenditure happens, and in wealthy countries, all the these are different sorts of countries, but this is Australia here. Expenditure in old age is higher than average, expenditure in young age is lower than average. All the tax is raised from this population, and all the money is spent from this population. And when this population is growing at a much faster rate than this population, you've got a problem. And that's the fundamental problem that needs to be fixed in aged care financing. So that's the work that we did in the Royal Commission, and Bridget Ballard from EY led this work, where we tried to kind of design a social insurance model which would basically survive and be able to fund aged care on its own. And essentially, this is the sort of tax rates that you would need. But to be clear, this is how much of your current dollars are spent on aged care. If you're in the sort of, would that be right? I think it's roughly right, yeah. If you're in the sort of 19% tax rate, 2% of those are going to that. So when I say that what we'd have to do, this is what the tax schedule would have to look like. If I was to have a levy to pay for all of aged care going forward over the next 50 years, this is what the tax schedule would look like. Of course, that isn't on top of the current tax schedule, because some of the money which we spend is currently got to be taken away from that. So about essentially, if we just said, let's take all the money which is currently being spent on taxes, how much extra tax would you need to pay in order to generate enough money to pay for all aged care needs? The extra, you need to increase the tax schedule by this much in the 19% rate up to the, the 45% rate would have to go to 50.5. The 19% rate would have to go to 21.3 in order to generate a revenue stream which was able to kind of pay for aged care over the next 50 years. So that's not impossible to do. It can be done. If you do that, it kind of smooths out over the long run. You have to reschedule this every, we gave a paper about this last year. You have to reschedule this every 5 years or so, but it can be done. but it requires all this problem to be taken away from government to someone else to solve. And it's kind of hard for government to give all that money up because that money is money it can spend elsewhere in the short term, because the long-term problem is a problem for someone else. I don't work for the government anymore, you might have noticed. Okay. A little bit light relief because, as you know, the means test in aged care is always problematic, but some people worry about their house, some people worry about their goods. Let me move on to why I think some of the other things. And basically I've called this section economics, because I think more than anything, what the aged care system needs to fix it is some economic thinking. The example I gave earlier about the domiciliary nursing care benefit care allowance is, I think, an example of economic thinking, where if an economist was to think about that, they would say, yes, of course, the efficiency solution is to be somewhere than another. This is the effective marginal tax rate, which is faced by a person who's in residential aged care at the moment. This is private income down here. So if you have a very small amount of private income, your effective marginal tax rate is 95% or higher at the moment. And normally we would say that's not a very good thing to do. And you can see, whereas the effective marginal tax rate way out here is nothing. And the reason why it's nothing out here is that the way the aged care test works is that you basically pay 50% of your income, 50% of your total income increase. Essentially, there are two things happening here. As a person earns money, their pension goes down. They lose 50 cents in the dollar. For every dollar they earn, they lose 50 cents in their dollar. And then government comes along and says, and we'll have another 25 cents for aged care fees. And by the way, you've got a marginal tax rate on top of that as well. Okay, so that's why you get up to 95%. Whereas by the time you get way out here, because there's a cap on how much you're allowed to pay in terms of fees, you're only allowed to pay $10,000 a year in fees in aged care, there's a cap on it. So no matter how rich you are, you stop paying it. Even though the average cost of residential care is $110,000, government says, I don't care how rich you are, you only have to pay $30,000, government will pick the rest of it up. Which means that by the time your private income gets out here, you're just being taxed. You're not losing any pension because you never got the pension in the first place, and you're not paying any marginal on the extra income you have because there's a cap on the total amount of fee that you can be asked to pay. Yeah, so it would be easy to restructure if you wanted to have a means test, was sort of like somewhat progressive. Now, Treasury would say, this is not an EMTR, David. They say two things. One is people are buying services here. It's not a tax. That's not true, I don't think, because the point about EMTRs is not that they're taxed, it's about the incentive that they give to people. And this gives an incentive to you not to have this much private income. It's much better than, there's no reason to have this much private income. If you have this much private income versus that, there's no reason for you to prefer to be here in this system. Okay. So that must be wrong. I think Treasury would also say, we don't care, David, because what can they do? Until they get to aged care, there's an advantage to them having this much income. Once they get into aged care, there's no longer advantage to them. Well, what can they do? They can't get rid of the income that they had, so that they'll be trapped. I'm not sure. I kind of vacillate backwards and forwards. Having designed that means test, I vacillate backwards and forwards on it. But when you look at the shape of it like that, it doesn't sit well with the idea of a progressive tax system, in my view. If anybody wants to know why all the other bumps, etc., work, it's because of the seniors and pensioners offset and the low income and middle tax offset and the way in which the Medicare levy exemption works, and the tax system is complex. And when you add that complexity on top of the aged care system and everything else, you get a curve which looks very weird. Okay, so I don't know what to do about means testing in aged care. What the Royal Commission both said was, don't have any. But that was in a system where the system had already paid for itself, because if clearly if you have a social insurance scheme where you've paid in through your entire life, you wouldn't means test the result at the end. But if we do want to means test it, we should do a little better. The other thing, of course, is that, and I will go back now and say this, the current means test is almost neutral to the amount of assets you have. It worries about the first $180,000 worth of assets that you have. Because if you've got $180,000 worth of assets, you're going to have to pay for your accommodation yourself. The means test then takes 1% of your assets above that a year. 1% of your assets above that. If you're sitting with a $5 million superannuation fund, well, again, the $30,000 cap fits in. So if you've got $5 million in your super fund, the government says, well, you can pay $30,000 towards your care, please, but the other 80,000 will pick up. Because the means test doesn't care about the assets that you hold. The means test also doesn't care about some of the assets that you hold. The house is like sacrosanct. Even if the house should be in play, even if you're the only person who lives in this house and you've now moved into a nursing home and the house is totally unoccupied, only $180,000 worth of the value of the house counts towards your assets. The rest of it just sits there as a free asset that you hold and is not counted in the asset test. That makes no sense to me at all in terms of equity. And one could totally redesign this income test and lower a lot of this EMTR by fiddling with the asset test and making it more stringent. And even if you want to protect the house for when their partner is still living in it, because the problem with the house is it's kind of hard to make it visible, even though we know that there are things like, you know, loan schemes, etc. But even if we say let's protect the house when someone's still living in it, there are all these houses in which no one is still living, but it's not counting in the asset test. All right, let me move on from there. Value for money. Yes. Have a value for money test. And this is a fundamental difference, I think, I was saying to the group earlier, between aged care and health. In health, we are very, very familiar with the fact that some things are worth doing and some things are not worth doing. In aged care, we have different tests, but we still do the same. I'll just say this now because in the NDIS Act says there's one concept of value for money in the NDIS Act. And essentially that concept of value for money is this the cheapest way to accomplish this? The Act never asks the question, should we do this? Is this worth doing? Is not a question that the Act asks. If a person comes and they have a need, they have a goal, and it will cost something to meet that goal, the Act does not ask the question, is this goal worth funding? It asks the question, what's the least money available necessary in order to solve that problem? That's not a value for money test, which I think can stand the course of time. And if I was redesigning the aged care system, which is what's happening at the moment, I would make sure that my aged care system didn't have that as its value for money test. Now, I don't think you can have the same value for money. I mean, fundamentally, health is different. We all know that health is an investment. Health largely pays for itself in the sense that, you know, we know that we get returns to the Australian economy from making people healthier. And so the health system pays for itself in a way in which the aged care system doesn't. Now, that's not to say that we shouldn't fund the aged care system and look after people. I'm getting very close to being in it myself. But it does mean that we have to think about it in a different way. It's not paying for itself. It's what we're choosing to spend. And sustainability depends upon two things. It depends upon people being willing to pay, as well as people needing the money in the first place. And people are willing to pay for things when they can see that they're getting value for money for what they're spending. So the big fear about spending too much on social welfare is that the taxpayer begins to say, why am I spending this money? There's also a problem, a competing optimization problem. Two things that you have to worry about in health, in aged care, I think, and in the NDIS. One is that you sell bundles of services, and it's always hard to know what part of the bundle is contributing to the outcome. So the idea that you can actually kind of, you know, sort that out is complex. The other problem is that the optimization solution to the system is essentially to maximize outcomes for you over the long term and minimize costs over the long term. The optimization problem for the individual is to maximize outcomes for themselves. They don't care about the minimizing. They're not paying for it, so they don't care about the minimizer. Those two optimization problems, yeah, the immediate maximization of outcomes versus the long-term maximization of outcomes and the minimization of expenditure are not the same optimization problem. And they don't have the same solution. They don't have the same solution, yeah, and indeed they have alternative solutions. Typically, one makes a capital investment as an insurer in someone because it reduces long-term costs. Or in healthcare, you know, you make an investment in rehabilitation because it reduces the long-term costs. In pure terms, the individual may not prefer one solution. The individual will have a different preference between those because they're not interested in the long-term costs. So there's this bundling problem, there's that problem. I mean, essentially, partly, I think that what it means then is that what we don't have, as I said before, is we don't have this quality. We don't have this way in which we kind of measure how we're going to do this optimization that both of us agree on. And someone's going to give a seminar here in a couple of weeks, I think, from some work NDIS has been doing with Monash about sort of like some sort of overarching mechanism for maybe trying to measure that sort of thing. I mean, I think the other problem is that, well, there are two problems. Campbell's law, basically. The way we should try and solve these things is essentially you build up all these quantitative kind of social indicators to try and work out whether you're spending the money in the right place. And then you start worrying about those social indicators rather than the outcomes that you're achieving. So you always have that problem. But then you have to remember Holstrom. Holstrom in sort of like impossibility theorem basically says that you can't actually solve this problem. There is no budget neutral solution which is Pareto optimal to this dual optimization problem. It just simply is impossible to solve. So I guess this is my research project for the next year or so, is to try and work out basically in theoretic terms, what does Holstrom mean for this sort of like problem which is faced by social insurance schemes. So that's, if anyone knows the answer to that, they can come and work with me. Last thing I want to talk about, please don't do this to me. Help. I have one more slide. I think I've got off a long enough. Yeah. What do you actually do? This is the budget line of an individual prior to intervention by government. And the individual essentially has a choice of kind of what sort of goods and services they purchase, which are not related to their disability or their frailty, and what sorts of goods and services they have, which are related to their disability or frailty. And everybody kind of finds themselves on this line somewhere, depending on what their preference curve is. Their preference curve will have a tangent to that line at one point, and therefore they will decide to spend this much on food and this much on disability goods because that's how they maximize their outcome. What happens when you give someone money in their plan or an aged care package is essentially that they get this budget line. We choose not to, we choose to have a rule which says you have to spend this on disability or on aged care. You're not. Now, that's a silly rule to have, as we all know from the economist's perspective, because it's an inefficient rule. I mean, your preference curve may mean that you actually want to spend up here, and we force you to spend here. So you actually are forced to an inefficient solution, one which kind of causes you to choose inefficiently. But we do that because the taxpayer who paid for this paid for it to be spent on something and would be unfortunate. So this is well known in America in the food voucher system. Food vouchers cannot be spent on alcohol. It's known that that makes the entire system inefficient, but the taxpayers just won't pay for it if some of the money is spent on alcohol. So therefore they have this rule, which kind of like makes the whole system less efficient, but at least gets the money in the first place. Now, this graph isn't quite right because in residential care or in the NDIS, this line is about $100,000 or $200,000, and this line is $20,000. So in fact, almost all the choices that you might make are out of bounds because the curve goes all the way along here. Moreover, and I didn't have time to draw these graphs because I was just thinking this as I was going along. Technically, we give you in the NDIS, the gain aged care, we say that we're meeting all your needs. The plan is meant to meet all your reasonable and necessary needs. So that means that this line is actually vertical here because you will spend all this money. You won't spend any of your own money on your needs, on your disability needs, because why should you spend any of your own money on your disability needs? Because the plan was meant to meet all your disability needs. So essentially, for a person in the NDIS, the curve is actually a corner solution. There's only one point that they can choose to spend at, and that point has zero probability of being their optimal point. So they must be choosing inefficiently. They must be not maximizing outcomes for themselves. And there must be an arrangement which would spend less government money, they would get better outcomes for themselves and spend less government money. But it's one that we're not allowed to get to. But it's worse than that because we have fully funded their needs. And then we've told them to go into a market economy and compete. But market economies don't work when there's no scarcity. And in this case, the consumer has no scarcity. The consumer essentially has the equivalent of an infinite amount of money to spend on whatever their care needs are. So they have no reason to bargain. We often say to people in the scheme, giving you 10 hours of care, but if you're really good and you bargain with your provider, you'll be able to get 12 hours of care. Why would you? Because if you needed 12 hours of care, we should have given it to you in the first place. Because the scheme says fund everything which is reasonable and necessary. So it's no wonder that no one in the scheme ever bargains below the price limit. They have no reason to. If they do, basically they're giving money back to government. And every solution you get is inefficient because everybody comes to the corner solution and everybody chooses a bundle of services to purchase, which is not their optimal bundle. And their optimal bundle would cost less than what that bundle is. So, I mean, it's just an impossibility. Well, there are ways to solve that problem, and that's the other issue that I'm thinking about. So any questions? And this is the aged care bond, which I now pass on to you.
All right, thank you, David. That was fantastic. I mean, you know, you had some great data in there. You've got some big thinking, and you've even got some schematics that we can use. I suppose a couple of questions. We only have a couple of minutes to go, but one of the questions is really around the role of quality, and in particular the role of measurement of quality, because you highlighted that within the Royal Commission, they noted that there is X amount of dollars that should have been spent on aged care. You've suggested that it should be up to, let's say, around 50 billion extra. Why haven't they been spending that? Well, is it because they've been able to get away with it? I.e., we don't know what service quality was being delivered. And now that we have a star rating system, do you think there will be more pressure on the government to be held responsible for the quality that's delivered?
In the best of all worlds, yes, but of course, we've built a star rating system where it's actually impossible to score more than 3. Well, the only way you can score more than 3 stars in the current star rating system is to deliver more care than what you were funded for. Because the star rating system essentially depends upon the number of minutes of care that you deliver, but you're funded for a certain number of minutes. So we've invented a star rating system where 4 and 5 is only possible if you go broke. Right. So I'm pretty sure there's a design flaw there. But yes, people now know what the problem is. But even then, there are lots of problems in the world. Yeah. And if you ask for the same problems, if you ask for different problems to be solved by the same person, they will optimize between them. Yeah. You have to separate these problems out. Yeah. And solve them separately to each other. Yeah. Okay.
And then just one more question, because we've also talked about, profitability of aged care providers, and we know that HACPA is going through the process at the moment of determining aged care prices for residential aged care and now home care. Traditionally, they look at the cost of delivering services when you talk about public hospitals. How do you think that pricing needs to differ to capture the needs of aged care providers who obviously, first of all, need to deliver a different type of care if we're going to meet the expectations of society, because that's what the Royal Commission says. Sure. But secondly, also needs to consider that profitability and that rate of return on investment.
Yeah. Well, differently to how they do it, that's right. So the NDIS, for example, has a pricing model which basically looks at return on investment, which includes something like a return on. I mean, it's not impossible to put a return on investment in a pricing model. There are reasonable ways in which you can work out what a reasonable return is for a given risk industry and then add that into your pricing model. Something else which needs to be added to the pricing model, again, we talked about this in the Royal Commission, is kind of the cost of innovation and R&D. I mean, sectors exist in the general economy. All sectors invest like 2 to 3% of their funds in R&D. That's how they become more efficient. Government never funds. Government may fund R&D, but it always funds it separately. It never funds providers with enough in there that they'll actually go and do the R&D. Yeah. And indeed, but fundamentally, there's some sort of problem as well. Like what's happening is sort of like a move towards the widget economy as well, I think, in aged care, where we're going to start to measure each of the individual things which are delivered and pay for each of those. That's what we do in what happened in the NDIS. But there's a problem there in the trade-offs as well. I mean, essentially, if you're a provider and you decide to buy a lot of care mats, which you're going to put out, because you won't need to go and check on people so often because you'll know whether they've moved and got out of bed, they need less care hours. So you'll get less funding. Yeah. You'll make a capital investment and you'll get paid less as a result of it because there's no return to you on the fact that you made that capital investment. So it has to be thought through. I've always thought that the kind of something which is good about residential aged care is that providers are paid for a day of care and then told to deliver that day of care with a level of quality and work out how to get that quality. We're moving further and further away from that because now we're saying, and that day of care will include 230 minutes. Yeah. So we're moving further and further away from a good, efficient solution to how to fund care.
All right. Well, thank you very much. Please join me in thank you. Like I said, fantastic presentation, great data and great insights. So thank you for coming.
Thank you very much.
Cheers. And thank you all for also coming to the seminar today. We do have other seminars that are on, so please keep an eye out for those. Thank you.